So what we are going to see today is constraint induced movement therapy. So what are the materials which can be used for restraining? You cannot tie the upper limb with a thread or a rope, so that with unaffected extremity with thread or rope, so that he lands up in injury or yes, some sort of a soreness as such. So what you have to do is you have to use certain things which are going to help the patient in smoothly holding the unaffected limb. Okay, because for every attempt he does with the affected extremity, there will be some sort of a movement in the unaffected extremity. So the thing with which you are covering the unaffected extremity should be very safe and secure. You can use a sling which is not going to hamper the limb. You can use a plaster cast, not like one which is used for the fracture patient. There are tailor-made plaster casts which are available. You can also use triangular bandages, like in a home situation you can use a uh, towel to hold it in a triangular bandage. You can use some splints. The splints you use for the cock-up splints, the static cock-up splint you use to hold the wrist in dorsiflexion, that can also be given to the patient so that he cannot manipulate any object with the unaffected extremity. You can also give half gloves which will restrict only his fingers, which will prevent him from using the fingers for functional activities. I used to give the smiley ball in the normal hand and put a socks over that, and I will tie the socks with a soft velcro, so that as long as this ball is there in his hand, he may not be able to use it for functional activities, because these things may not be available with the patient. I'm not a person who will ask the patient to buy a sling or buy this thing or that thing, splints or something like that. I will do my treatment with whatever is available in the patient's house, because they have already spent so much for their acute phase. So as a physiotherapist, you should also look into the economical constraints of the patient. So I normally take a ball and keep it in the hand, and then over that I'll put some gloves. Maybe the gloves should be completely washed, and keep a gloves on that and put a velcro. So that ends the problem. So the material what you are using for the unaffected extremity, you should remember that. Please don't give it. Come and ask me that, sir, you told me not to use splints, and now you are advising to use splints. I'm here asking you to wear splint for the unaffected extremity. Okay. So um, yeah, this is 10 into 10 into 10 eligibility criteria in selecting a patient for CIMT. You cannot select every patient for constraint induced movement therapy. There is a criteria whom you can select and whom you cannot select. Very importantly, you can select patients if they have 10 degrees of active wrist extension along with radial deviation. If only they are able to do at least 10 degrees of wrist extension, this much, then you can put them in constraint induced movement therapy. 10 degrees of active thumb abduction. So thumb abduction, that means this is along the plane of the fingers, and this is abduction. So when the person is doing an abduction, the thumb comes in opposition to the all four fingers. So 10 degrees at least. 10 degrees active extension of any other two digits, at least two digits. Maybe normally where it starts is the movement starts in the lateral two fingers, that is your index finger and the middle finger. You should have a little 10 degrees of active extension of these any two digits. Then these 10 degrees are available, means this patient is eligible for the constraint induced movement therapy. So constraint induced movement therapy is always preferred for the upper limb. That is why this 10 to 10 into 10 into 10 rule is given only for the hand. Please don't ask me whether can I constrain the lower extremity. That is not for the lower extremity. For lower extremity, we say forced weight bearing. We can always use this, called as forced weight bearing, where you give some unsteadiness to the unaffected extremity, or you make the unaffected extremity move forwards in case of like a stepping, where the affected limb is forced to bear the weight and the unaffected limb is moving. So it doesn't comes in constraint induced movement therapy. So always when it is constraint induced movement therapy, it is about the upper extremity. Okay, selecting a patient is continued. Limited spasticity should be there according to the modified Ashworth scale. I did not tell you about spasticity as a major criteria in the initial phases of constraint induced movement therapy, because as such constraint induced movement therapy do not take into consideration the spasticity. But recently researchers have said that if there is a spasticity which is like sort of a clonus of the upper extremity, it is very difficult to put these patients onto CIMT. So this research have come up in 2010, maybe later 2010, that spasticity should be limited. That is, it should be at least 0, 1 or 1 plus, because patients may present in later stages of stroke, like in a very chronic stroke where even passive movements is difficult in the upper extremity. For those patients, if you do a constraint induced movement therapy, that is going to result in no recovery or patient becoming very psychologically depressed. Ability to move the affected arm 45 degrees of shoulder flexion, abduction, and 90 degrees of elbow extension and wrist extension. Elbow flexion and extension. So these are basic things, 45 degrees of shoulder. Now you may ask me, sir, for a patient who is able to do wrist extension, finger extension, thumb abduction, shoulder flexion, abduction, and elbow flexion and extension, why there is a need for constraint induced movement therapy? So this is a very important breakthrough point, because once the patient gets minimal activity in all these things, they will start moving it in an abnormal manner, or they may not know that they can even improve from this point onwards. If they keep moving continuously, they will not tap the potential. That is when the CIMT is going to be very effective. When the acute phase, the patients who are slightly showing a recovery trend in the first 2 or 3 months, if they are put in CIMT, they are going to improve far better. Patient should have adequate balance in sitting. If the patient is not having an adequate balance in sitting, if you're going to constrain the affected limb, unaffected limb, which was used for maintaining balance, their entire concentration will be on maintaining the balance, and they will have apprehension to move the affected extremity away from the body. Always imagine, if both the hands are tucked towards the body, the line of gravity is within the base of support, and the center of gravity is going to remain as low as possible. That is the most equilibrium stability they can get. But if they try to move one limb upwards or forwards, this line of gravity is going to move away from the base of support, or the center of mass is going to increase. So that is going to give an apprehensive attitude to the patients to move. So they should have an adequate balance, at least to sit without support in high sitting for at least maybe 15 to 20 minutes is sufficient. Minimal cognitive dysfunction. If all these things are perfectly there, but still the patient is having some cognitive deficit, patient is not having attention, patient is not having proper memory, then it is going to be an uphill task for the physiotherapist to make him memorize all the activities, and it is going to be very difficult for him to gain his attention when he's treating for CIMT, because CIMT is used for more than 3 hours. It is more or less like making students sit for 3 hours of neuro classroom and teach them neurology. It is that difficult for the patients to sit and concentrate if they have cognitive dysfunction. So cognitive, I mean the higher mental function, that is conscious, comprehending, orientation, memory, and very importantly the attention. So these 5 things are the higher mental function. If they are not having a proper higher mental function, or otherwise called as cognitive function, then it is going to be difficult to give CIMT, because the behavioral consensus will not be there. The patient will not understand the need for the CIMT. Okay. Next is, there are different models of CIMT. The first one is the unmodified constraint induced movement therapy. where 90% of the individuals, 90% of the individual waking hours will be used for constraining. So this is a huge amount of time. For example, if the patient is awake for say 14 hours in a day, in that 14 hours a day, you are going to constrain him for almost 13 to 12 hours per day. This is a huge amount of time for the patient. Only activities involving toileting, hygiene, and bathing are permitted. That is, the constraining will be removed only when the patient goes for a toilet or a hygiene activity or bathing activities. Apart from these three activities, most of the time the patient is going to be in a constraint. So how long they will give this therapy? 2 to 3 weeks. So after 2 to 3 weeks, they will go for a analysis. Here in constraint induced movement therapy, the pre-test and post-test of outcome measures is very, very, very important, because with that only you're going to gauge how much of recovery the patient is showing. Fine. So that is very important. So second models of CIMT is modified CIMT. So why this modified CIMT has to come compared to the previous model is, people who administer CIMT did not find that much amount of success in all the patients they treated. They were able to find some results, but they were not able to generalize this for a wide variety of people. So they said, we have to come up with a model which is realistically practical. The duration of the intervention should be diminished, so that the patient is not taken by a fear factor that every day they get up in the morning they will be constrained, and they should not have this fear of constraint induced movement therapy. So they reduced the time to 3 hours per day for 5 days in a week. So 2 days they will get relieved from this constraint, and in a given day only 3 hours will be used. So 15 hours per week is the plan what they had. Minimum of 4 successive weeks. So like that, 15 into 4 weeks, that is 60 hours of constraining, and after 4 weeks they will see how far the patient has recovered. In total there will be 20 treatment sessions containing 60 hours. This you can implement in your patients to see how far they are recovering. So what are the side effects of CIMT? When you are not constraining the affected limb, unaffected limb properly, you may get burns because of friction, or the heat which is generated inside can also cause burns. In case of plaster cast, this is very common. Minor skin lesions, where the patient is putting a lot of effort when he is moving the affected limb. He also puts the effect on the unaffected limb. We have seen that as an associated reaction in Brunstrom's therapy. And muscle soreness will also happen in the affected limb. Muscle soreness is nothing but increased effort of all the muscles of the upper limb can cause soreness, like how you go to gym, or when you go for a trekking on a fine day and the next subsequent day you're not able to walk. That sort of a soreness can be present, and it is there is nothing harm in giving 1 day rest in case if the patient is having soreness, for the delayed onset of muscle soreness to come down. Next, the frustration. Frustration happens when there is an unsuccessful attempt with the affected limb. When it is guided properly by the therapist, this unsuccessful effort is going to become a successful effort, and the frustration is going to come down. So always you should have someone helping the patient when they are doing the constraint induced movement therapy. So with this, we come to the end of this constraint induced movement therapy. It's a very useful therapy. If you can give 2 hours for the patient to help every day, the third hour can be maintained by the caregivers. It can show a significant result in your patients. So you have to come to a consensus with the behavioral consensus is very important. The pattern planned activity should be there, subsequent practice should be there, and very importantly the intensity of the exercise should be at least for 3 hours in a day. If you do all these things, selecting the patient is also a very important thing for the CIMT. That is when most of the therapists fail, and they say that CIMT is failure because they are not selecting the patients properly for this. If you use this 10 into 10 into 10 rule, along with the 45 degrees of shoulder abduction and flexion, elbow flexion and extension, if it is available in these patients, that is going to give good results. So if you have any doubts, you come and discuss with me in the group. I'm ready to discuss in the group. Thank you. Thank you so much. Have a great day. Bye.